and Dr. S.S.V. Ramana sir and Guntur Orthopedic Association for giving me this opportunity. I would like to present a case of, it's a recurrent case of tumor-induced osteomalacia. I think many of us must have studied all these things in post-graduation and further residency. So in my experience, I must have done around 7 to 8 cases. I would like to present this special case because it is one of the case we need to know and open our eyes. I would like to keep it small and short and crisp. A small intro about this tumor-induced osteomalacia is, in contrast to traditional neoplasms, it's a paraneoplastic syndrome. It causes symptoms because of the hormones released by the small mesenchymal tumor. In this tumor, high amounts of FGF23 is released. And what does it really do is, this FGF23, it allows the kidneys to excrete unusually high amounts of phosphate, and thus hypophosphatemia will be there, and defective bone mineralization will be there. And most specific and sensitive to detect this sort of tumors is GA68 dot scan. So in our case, he is a 50-year-old gentleman who presented around 15 to 20 years back with severe muscle cramps and bone pains, and he was unable to even get out of his bed. So endocrinologist workup has been done, and they have diagnosed this tumor-induced osteomalacia, and it was excised 15 years back. So he was symptom free for all these many years. Again, after 15 years, he comes up with the same bone and muscle pains since 1 year. Again, they have worked up and put him on just phosphate and vitamin D supplements, and phosphate levels have never been above 1.5. This is the cause of symptom. So 15 years back, since the same thing happened, so the same workup would have been done, and this is the present situation. So the dot scan had picked up 2 lesions, one in the greater trochanter and one outside the greater trochanter. You can see this one and that one, the corresponding CT slides over there. So the treatment would be excision of the tumor, right? Everyone thinks it's so simple, right? This is another slide. But we did it wrong because we took MRI guidance. Because usually in my previous cases, I used only CT scan because it was only a bony lesion. So I went for en bloc excision of the whatever the region of the bone over there. But here we had a soft tissue lesion as well, lateral to the greater trochanter. So you can see in this slide, yeah, this one, that's the second lesion. So I thought MRI would be much more apt. So I took MRI guidance and gone for excision. Somehow this time it was in the posterior portion of the greater trochanter. So en bloc excision of GT, I thought it would damage the medial circumflex artery and it would end up in AVN. As he is already osteoporotic, that would be a disaster. But somehow I went from the lateral approach and curated the whole trochanter and mistook the location of soft tissue lesion first, and I missed it completely. So the phosphate levels didn't pick up and FGF23 levels were still high. So the first surgery done by me, it's a total failure. But somehow we took the patient's trust, and after 20 days we went in for a dot scan again, and we saw that we didn't do anything, just curated the greater trochanter and put some cement over there. We left the lesions. 2 lesions were there itself. 2 lesions were there itself. We couldn't do anything. So now what to do? Because he is not a right candidate for total hip replacement as well, because his bones were too osteoporotic. So and the soft tissue lesion is so small, it was measuring around 8 mm into 8 mm. So this spot, so we thought we'll go with another approach. So we had gone for a contrast enhanced CT scan to locate the lesion. Okay, now you see the cuts over here. We have the cement over here, and posteriorly the lesion is there. And on this contrast enhanced CT also, the soft tissue lesion we picked up over here, and we had put a needle from the skin to that lesion over there, that soft tissue lesion, and located the lesion on a CT scan. And I used a methylene blue dye. I injected into the needle over there to locate, so that intraoperatively when I go there, I can see the lesion stained with methylene blue. Because these sort of mesenchymal tumors, they don't look different from soft tissue. You can't really pick them up. So a standard posterior approach was used for the greater trochanter lesion, and you can see the lesion. It looks like a simple bone. It doesn't look like any tumor. So luckily we didn't injure the medial circumflex artery, and we removed the posterior portion of the greater trochanter, and via separate anterior incision I approached this anterior lesion, and you can see actually the tip of the needle over here and the stained methylene blue over here. So around 5 centimeters of soft tissue and fat, I had removed it, and this is the GT, hollow GT over there, en bloc excision of the GT. This will have the tumor inside. And this is the soft tissue lesion which we had pointed on the lateral side of greater trochanter. Now the patient is completely symptom free, and his phosphate levels, for the first time in 20 years, it has come about 3.6, and FGF 23 levels came down suddenly, and histopathology has also proved that it's a mesenchymal tumor releasing this FGF. What did we learn from this case is en bloc excision is always needed, not curettage for these endocrine tumors. And soft tissue lesions, they need some extra guidance for complete excision, because they may be in a region where we can not really see them. So we need some extra guidance such as CT scan or methylene blue dyes or whatever, so that you can locate them and excise it. So special thanks to Dr. Srikanth Kongra and Swapnika madam for referring me this case and placing trust for this difficult cases as well. I would like to end my talk with a small philosophical. It's scientifically proven. Karma always hits you like a boomerang, but it will always give you a second chance. The key thing is only awareness of the things that happen around you. Thank you. Any questions?
How do we identify for the first time? Because this patient previously had the tumor.
Okay.
You could recognize it. The patient comes to us for the first time. How do we assess that patient?
First thing, if any patient comes with this sort of muscle pains, body pains, the first workup should include this calcium phosphate, alkaline phosphatase, vitamin D, routine endocrinology workup. If any hypophosphatemia, severe hypophosphatemia which is resistant, then this endocrinology workup should be extensive, because not only blood markers will change, there will be urinary markers as well, which are complicated, the urinary phosphate ratios and everything. If you have any small doubt also, it is better to refer to an endocrinologist for this workup, because this is a one-off case. We don't see it so regularly. Okay. So, and whatever the case you see, it might not be tumor-induced osteomalacia. It is only one eccentric diagnosis. So it is always better to have an endocrinology workup, then get to these scans. These gallium scans or dotatate scans or whatever it is, they help you point out that lesion. Where is this? Usually they occur under hip only. Okay. After that, you need to have an MRI or a CT scan for better localization, because in my residency I have done around 4 cases. in after coming here also I done around 4 cases, 2 in distal femur, 2 in proximal hip, proximal. But soft tissue lesions are much more difficult. In bone you can actually locate and take out that thing and block. But you need to have the dotatate scan or some octreotide scan and then local CT or MRI.
And you injected the methylene dye?
Yeah.
Under the CT guidance?
CT guidance. So we located that lesion under contrast enhanced CT and put that needle and then injected that methylene blue around 1 ml.
Will it stay there only? Methylene blue till the surgery is over?
Yeah, that is why just before it was around only 15 minutes before surgery I had injected it, gone into the surgery.
So you kept the needle in situ?
Yeah, needle in situ. I think you must have seen that thing.
Yeah.
I have taken the patient straight from CT scan to theatre so that nothing is disturbed. We had dynaplast and everything. So methylene blue usually it stays because it's full of fibrous tissue over there. If it's a fresh virgin tissue, the lymphatics will be much more faster. But it's already fibrous. We had gone I think 2 to 3 times, so it will stay a bit more longer. This is my first time also I am trying it. I don't have really evidence to prove that this is the right method, but this is what we did and hit it in the second chance.
Getting paraneoplastic syndrome, what is the chance of metastasis?
Sir, paraneoplastic syndromes, they
Mets రావా దీనికి అసలు?
mets అనేవి లేవు sir, because they're it is not a neoplasm. It is symptoms are due to the hormones released from the tumor.
అవును. So the same kind of tissue cannot seeding of the tissues అట్లాంటివి ఉండవు.
Remnant అయితే ఇప్పుడు ఇది ఫస్ట్ టైం 15 years బ్యాక్ చేశారు సార్. 15 years back they must have left some cells because the location is again in the GT and again in the scar tissue.
Yes, scar
Right.
tissue is probably because of the surgery, initial
Ah.
surgery,
They must have seeded
soft
it
tissue.
soft tissue. It took around 15 years to grow the lesion back again. So this is not metastasis, this is something like residual. And there is a chance that in literature it is described that they might develop these sort of lesions somewhere else as well.
Exactly.
But this is not metastasis.
Not metastasis.
This is
De novo just.
de novo, it can happen. So, thank you.
The lesions are not very surgical resectable.
If they are not resectable, I think Dr. Srikanth has told that, Dr. Srikanth has actually told me about a few patients he had been keeping them on long-term vitamin D high dose supplementation and phosphate supplementation, which you can't really imagine also, because they will be taking around 3, 4, 5 grams of phosphate and calcium every day it seems, which we can't really monitor them also. In our orthopedic setup, we can't really do that. You can't even really imagine 5 grams or 6 grams of phosphate they will be eating like that. So it's very difficult for us. Even we advise only 1 or 2 tablets of calcium, but they will be taking more than that. They will be taking the 6 or 7 doses and continuously every 10 days or 15 days they will be monitoring it seems, so that they will not have any electrolyte imbalances. It's very difficult, but you can have non-resectable tumors as well.
Thank you, sir. For today's presentations, I'll be the last.